Alright. Looks like we've got a good number of people coming in. I'm going to give it just a minute or two. Let everyone load in. So, good. As you get in here, please go ahead and say something in the chat so I know who I'm working with today. Everyone load in. Let's see, 14 people. Hi, Gianna, good to see you. Wonderful. Let's see, is there a good position to put this thing in? Let's try this way. That'll do just fine. 16 people, 2 who have working mice. This is good. Biggie, good to see you. Amon, good to see you. Wonderful. Wonderful, wonderful. This is going to be great. All right. All right. Ashlyn, good to see you. There we go. Now the party's here. Great. Good, 19 people. All right. So we're going to go ahead and get started. Assume everyone who's not here has died terribly. Welcome to the last of my reviews before your second exam. This is widely considered to be one of the harder exams because the brainstem had a lot of stuff going on. It's a little bit similar to the spinal cord, just enough to confuse you if you don't know what's going on. But we have to tell apart fibers and nuclei. And there's a bunch of different levels, and they look kind of similar. So what we're going to do tonight, instead of just a barrage of questions, is we're going to go on a journey from the top of the spinal cord all the way up into the top of the brainstem. And if you can follow the narrative, if you can follow what's happening at each level, then you're going to have absolutely no problem on the practicum. All right? So, without further ado, we will get started. And I will say, since spoiler alert, I'm going to post this particular lecture because I know how hard this one is. Do you guys a favor. I'm going to post this lecture. So if you're watching this on the YouTube recording after the stream, then you'll have to bear with us as we do the live questions, and you'll be sort of bored. But that's not important. So, moving right along. This is where we start. And this is where we start in lecture when we spoke about the spinal cord. We start at the bottom. And what I want you to notice about this is that it's very, very similar to the spinal cord. And what do I mean by that? Well, we had the dorsal columns in the back on the spinal cord, at all levels, right? And that's exactly what we have here. Nothing has changed. You see this sort of similar looking structure. You have the left side and the right side. There's a couple things that are different, but we'll talk about that. But the trick is that if you see this, if you see something, you go, oh, I can barely tell if this is spinal cord or if it's brainstem. You must be in the medulla, because the medulla is at the bottom, and it's right coming out of the spinal cord. So this is exactly what you expect. Okay? So we're going to talk a little bit about this level and what's useful about it before moving on. So first, we want to identify this really useful structure. Right in the front, where you would expect, on the ventral side, we said ventral is motor in the spine. Well, as we get into the brainstem, ventral is still motor. So we see this thing, looks like the spine, the back is sensory, the front must be motor. And so we have the decussation of the pyramidal tract, which is the motor fibers coming down, and this is where they cross. And we're going to have a couple of questions about this now, because this is very important. A lot of people mess up what's ipsilateral, what's contralateral, and what do lesions at different levels mean. And it starts with tracking what happens right here at the decussation of the pyramid, which is the most obvious and possibly high-yield decussation that we're going to talk about. So we like questions. We're going to start with a question. Right here, we're at the bottom of the spine, right? The pyramidal decussation. And what I want to know is if we go right below the end of the pyramidal decussation and lesion the corticospinal tract, the pyramidal tract, what is that going to do? And I mean relative to the lesion, where will the damage be? So go ahead and put your answer in the chat, A, B, C, or D. And let's see if we can get this one right. Good, Jenna. Let's see if anyone else has any ideas. Nandita, good job. Amon, good. Yeah, the answer's coming in. It helps. You should all be putting out an answer. It helps you to be confident and say something. Don't let the first time you do that be on the exam. Good, Joanne, Sheena, nice. Good, and you're all correct. It's ipsilateral. We spoke about this in the spine, right? If you lesion the right side, you get problems, you get weakness on the right side because everything has already crossed over. Now, whether or not we're in the spinal cord or right at the end of the brainstem in the medulla after the crossing over, it's still ipsilateral. Post-crossing, the symptoms are ipsilateral. So, take that concept and apply it to this question. If you got the first one, this one should be very easy. So go ahead and have a go at question 2. All right, let's see what we've got. God bless Streamlag. It makes it a lot more interesting, fun, challenging for me. Good, Gina, Joanne, Ayman, Nandita, good job. Haju, nice. Good, you're all on top of this. So that's exactly what you want to know about the pyramidal decussation. If we're below, lesions cause ipsilateral symptoms. And if we're above, then the damage has to cross over first, right? If we want to think about it that way. So it's going to cause contralateral symptoms. So, and I have a little note here. Here's a simple rule. Damage before the crossing, contralateral. Damage after the crossing, ipsilateral. If you guys are tracking that, and it seems like you all are, you're not going to mess this up at all on either the practicum or the exam. Great job handling those first 2 questions. All right. So we're still at the same level, not moving on yet, and the question is, what else is going on here? We've identified the pyramidal decussation. We also have this thing. So what is this thing at the end of the arrow? And I know it says SPVN, right? Very obvious. Spell it out. What is this thing? And I want to know, what does it do? In your own words. So let's get that in the chat. Get some discussion going. Okay. It's going to really help if when you see these things, you can immediately tie them to an English clear name. If you can immediately tie them to what they do and not just, a mass of color on the image. So that's what I'm trying to elicit with this question here. So let's see what we've got. Good, Nandita. It's the spinal nucleus of the trigeminal nerve, which is cranial nerve 5. And if you were a Roman, you would know to spell 5 as a V. Okay? So it's doesn't stand for vestibular. I guarantee you there will be someone who didn't come to lecture, didn't come to reviews, and they will pick vestibular on the practicum. They will get it wrong. So this is the spinal nucleus of the trigeminal nerve. Good job. Now the question is, what does it do? And Amon hit it right on the head. Pain and temperature information. All right. So if I stab you in the face with a fork, for example, if this nucleus is not working, you won't notice. But presumably it's all working in you guys, which is why it's considered impolite to stab people in the face with forks. So we'll do a little bit of etiquette alongside our neuroanatomy tonight. Don't stab people with forks. Great job. Great job. And you can see right behind it, right here, if we have a nucleus here, it makes sense that we're going to have some kind of axons behind it. And oh look, we see these dark stains that indicate axons, so we must be looking at the axons. Is it contralateral? That is the question, and I don't know if okay, I didn't add any extra slides to discuss that. But, so what happens, and you'll have to sort of imagine because I don't have visual aids for this. If we have pain, and let's look at the ventral surface. So right here, we're looking at the ventral surface. If we have pain come in from the right side of this patient's body, coming in this direction, the first thing it's going to do is the fiber is going to trace down, all the way to right here, which is going to be the spinal nucleus of the trigeminal nerve, and it's going to synapse. Then what it's going to do is it's going to cross over, and it's going to climb all the way back up to the thalamus, synapse, and go to the the pain centers of the brain. So is it contralateral? As it comes in, and that's the thing, you can't just ask if something is contralateral. You have to ask, would symptoms be contralateral to a lesion of this thing? So if we're talking about a lesion between the face and this nucleus, then we're going to have ipsilateral symptoms. Ipsilateral symptoms, right? Because we damaged here, the pain loss is here. But it does cross over, so it goes down and then it crosses over. And if it's already crossed over after the decussation, then you're going to get contralateral symptoms. And that should make sense, right? So if the nerve is picking up pain here and I cut it between here and the nucleus, then here is where the problem is. The cut is here, the damage is here. But if we let it go down and cross over and come up and I cut it somewhere here, the cut is here and the damage is on the other side. Now, this is something that confuses a lot of people because this is a very weird nerve and it's a very weird path to trace. But you tell me right now in the chat, does that make sense? Does that clarify your question? Because it's a very important one, and if it doesn't, I definitely want to address it right now. And as usual, I'll come back if the answers address it more, since there is stream delay. Okay. Okay, great. And of course, always, 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 if you're going to use the word contralateral, ipsilateral, ask yourself before you think that word. Ipsilateral to what? Contralateral to what? That's going to stop you from getting confused. So we got some other stuff going on here. We have this NG over here, and we have this NC over here. Ashlyn's still a tad bit lost. Okay, we can go into it. Explain again. Okay, all right. I can do that. Let's see, what's the best way to do this? Let's do this, and I will pull up the initial slides, and I'll show you the trace of the pathway, which might help. It is kind of tricky. Yeah, the trigeminal nerve is a really freaky nerve. It does some freaky stuff. I'm sure there are neurosurgeons who would agree with me. Okay. This slide should do. Will it? Yeah. All right. So let's switch over to this and present. All right. So let's have another go at this. It's not all that complicated. It really, really isn't. It seems complicated because you've never seen anything like it before. And if you were an engineer designing a robot, you wouldn't think, oh, let's have a signal come in here and then go down just to come back up. Why does that happen? I don't honestly know, but it's not that complicated. All it is a bit different. So let's trace it, okay? We're going to start with the stimulus. Now remember, when we're looking at an image, this must be the dorsal view because we see the colliculi of the midbrain. So this must be dorsal. So that means this is the right side of the patient. This is the left. That is not supposed to happen at all. Oh dear. Okay. So this is the right side of the patient. This is the left side of the patient. And let's trace what happens. So we're talking exclusively right now about pain and temperature. So let's look at pain and temperature. A signal comes in right here on the far right side, and it comes in, it goes down. So let's make sure that you guys are on the same page here. What is this green nucleus? What is this green nucleus? Very easy question. But it's very important that you're clear on where in the pathway this thing is. If you're clear about it, you're going to be able to make sense of the rest. But if you don't know what this thing is, then nothing I'm saying will be coherent. So you tell me, what is this green thing? Let's see. Yes, good. Exactly. That's exactly what I'm looking for. Okay. This is the spinal nucleus of 5, the spinal nucleus of the trigeminal nerve. Okay. So, key point. Pain or temperature came in on the right. We're still on the right. We are still on the right. once it hits the nucleus, that's where it crosses over. So it crosses over and it's going to climb up and project to the thalamus. And we're not talking about cortex yet, so don't worry about it. It goes to the thalamus. Just accept that as gospel and move on with your lives for right now. We will talk about the thalamus in depth, but that's not right now. Okay? So, just recap real quick. We went from the face, in, down the same side, to the nucleus, on the same side. Then, down here in the medulla, after the nucleus, we cross over and make the journey up the contralateral side, so the side opposite the stimulus, up to the thalamus. Okay, so now here's the question. We're going to answer 2 questions, and if you could answer both of these questions, you're fine on the spinal nucleus of 5 and the trigeminal pain pathway. You're done. All right. If I lesion the trigeminal pain pathway right here where my laser is darting around, are the symptoms, is the loss of pain going to be ipsilateral or contralateral to this lesion? Okay, if you can answer that, you're well on track. It's that and one more question and you'll be good on this. So you tell me, we're lesioning right here. Do we have ipsilateral or contralateral symptoms? Perfect. Perfect. Good. Good. Awesome. Very, very good. So we're before we crossed over. We didn't cross over yet. Everything is on the same side. Damage on the right. Pain and temperature signals coming in on the right. Won't be able to make it. That's exactly correct. Okay, and Ashlyn, I want to hear from you as well that you're making sense of this, right? So be vocal, okay? So then we're down here. We're at the nucleus. Let's say we knock out the nucleus. We kill the nucleus. Are we going to be ipsilateral or contralateral to the resultant damage? So again, we take a screwdriver, stab this nucleus, destroy it, okay? Will we get loss of pain and temperature on the ipsilateral side or the contralateral side? Follow the same logic you just used. Very good. Awesome. So again, we have not crossed over yet. We're still on the same side. Also ipsilateral. Good job. No question marks. No question marks. If you put a question mark in, type it in again, hit enter without the question mark. Believe in yourself, all right? Confidence precedes competence. Okay? So, after the nucleus now, let's say we're over here. Okay? So we take a shovel, bash this dude in the head, and we impinge upon this tract. We'll talk about that, Bray. We'll talk about that. So let's talk about this tract now. We're up here. We shove a shovel into this guy's head, and we cut this thing. What happens? Yes, Gina, that is correct. This would be a second order neuron. So what happens if we lesion after the spinal nucleus of 5? What happens? Contralateral loss of pain. Very good. So we already said the signal is coming in from here. It's already crossed over. So if we cut here, we damage this signal, this one on the right. Okay? So we damage that signal, means the symptom, the loss of signal, we're losing the right signal even though we're lesioning on the left. That is contralateral. Okay? Why wouldn't it be bilateral? As you can see here, pain comes in, this is the right side, talks to the nucleus on the right side, crosses over. It wouldn't be bilateral because if it were bilateral, we would damage this nucleus and the copy on the other side, the spinal nucleus of 5 on the other side, which is handling pain from the other side. If we damage both of them, yeah, it'll be bilateral. And in a little bit, we're going to talk about some examples where we do get bilateral symptoms, and that's going to be a bit more of a useful example for you. Now, this is very complicated. I admit it's a bit hard to get your head around at first, but if you get this, trust yourself on the exam. This is a level of detail. This is not your neurosurgical residency. This is an undergraduate level neuroanatomy class. All right. Yes, it will integrate with the spinal thalamic tract. That's correct. Very good. Any questions about this thing? I welcome them right now. If you're good, then you're good, and we will move on back to my beautiful slides, which are all plagiarized from the parent lecture. Okay. Great. Okay. So we sort of got sidetracked on this thing. That's good. It's one of the more complicated things on this exam, but you guys are fine. Yep. You're correct, Haju. That's correct. All right. So other salient points at the bottom of the medulla. See, we're still at the bottom of the medulla, but a lot's going on. We have the nucleus gracilis, the NG, and we have the nucleus cuneatus, the NC. You remember legs are on the inside, which we spoke about on the spine, right? It comes up, and then the arm fibers come in on the top, which is what you see. And same thing with the nuclei. The nucleus gracilis is on the inside. Nucleus cuneatus is lateral, okay? This is the gracilis more medial, cuneatus more lateral. Remember that however you want. And you can see, right, you have basically the tract is coming up, and then it just sort of goes like this, and synapses. Oh my God, I'm the worst online TA in the flippin' world. Great. Okay. You see, I got my hair did yesterday, and I feel like I'm looking so good. I just thought, never mind. Okay. All right. So, that technical trouble resolved. You have the fasciculus, gracilis, and cuneatus, right? They come up, and they sort of go like this into the spine, and in the spine, you have the nuclei that they're going to synapse on, the gracilis and the cuneatus, okay? So that's what we're seeing here. The fibers are coming up on the outside. They're coming up, and then they just pop a little bit inside, and they synapse. What do they do after that? Don't worry about that right now. We're going to talk about that on another slide. Okay. And of course, this AH is the Adam Howard nucleus. It was named after me. Remember that for the exam. All right, great. Spinal thalamic tract. I will point that out, not because it's doing anything interesting here, just because on the spine, the spinal thalamic tract was in this location. We're in the bottom of the medulla, and the spinal thalamic tract is in the same location. So if you get a question on the practicum, looks like the spine, and has like a dot here, says, what is this? You're like, well, in the spine, that's STT. This looks like the medulla. This must also be STT. And it is. That's exactly what it is. Okay? Good. Moving on. So, here's a question, okay, which is sort of an exam-style question meant to test practical knowledge. So I want to hear it in the chat. You can go back to the slides if you want, do whatever you want. But I want to know which nuclei, I want 3 of them that we spoke about, are evident at the level of the pyramidal decussation. So type the answer out in the chat. There are no letters here. I want it to be recalled. You tell me what I'm asking for here. It is the spinothalamic tract. Yes. S-spino T-thalamic T-tract. That's right, Viggy. Exactly, Haju. Right on the ball. So we've got the nucleus gracilis, which is the most medial structure. Then we have the nucleus cuneatus, which is a bit more lateral. And then we get the spinal nucleus of 5, which is the most lateral structure, the most lateral nucleus that we're going to be discussing for the purposes of the exam. Awesome job. Good. Okay. Now, we're going to move a bit up in the brainstem. The key to success tonight and the key to success on the practicum is to use easy landmarks to help you locate more elusive ones. So for me, I know where the nucleus gracilis is, I know where the fasciculus gracilis is any day of the week. But maybe I forget where the cuneatus is. I know that it's the next thing lateral, right? So I know one thing, I know the relation of the other, I know where it is, okay? Or you can go STT, and you know it's the spinal nucleus of 5 is going to be between that and the nucleus cuneatus, and then you'll be able to localize that. And we're going to talk about some more high-yield landmarks right now. We spoke about pyramidal decussation, that's another good one. Okay, so here we are, moving on up a little bit higher. What is the same? Spinal nucleus of 5, still there. Same spot, okay? Remember, the spine is the brainstem, everything, is a three-dimensional structure. So we're not talking about a nucleus that goes like this. It is a nucleus of cells. It has a bit of depth, and we're just moving a little bit deeper into it. We still see the tract, okay, the tract that's coming down and innervating the spinal nucleus of 5. Spinothalamic tract still there, still in kind of a similar place. We also see the pyramids still there. We'll talk about this in a little bit. It's not really obvious what it is at this level, but some of you might know. But there are two big players we want to identify, okay? Besides these nuclei, we've already spoken about those. Number one is M. M is the medial longitudinal fasciculus, which is responsible for coordination of eye movements. It's important to note this thing because it stays in the middle for several levels. It's in the middle right now. We're going to do another section in a little bit. It's going to still be in the middle. It's going to still be in the middle. And by the time it's not in the middle, it's still in the middle. It's just done. So this thing runs in the middle from one section of the spine to another, and it does not move. That's useful. What's also useful is to track the ML, the medial lemniscus, because it moves in a very, very predictable way. So if we look at where the ML has moved from the midline, and remember, we're still in low-mid medulla. So if this medial lemniscus has moved from the middle, something has happened, which we're going to talk about. Sorry about that. And the occurrence of that thing, the presence of those structures, will tell you exactly where you are. And all you had to track was a medial lemniscus. All right. Things to note. This is still the medulla. Why? There are no transverse fibers. You're like, what are transverse fibers? Don't worry about it. We're going to see them in a minute. And it's going to be very, very obvious. And if you remember from lecture, they are very obvious. And if you see them, you're not in the medulla. If you don't see them, you're still in the medulla if we're going from the bottom up. Okay? The M helps you orient. We spoke about that. We also want to take note of this thing out here. The lateral cuneate nucleus is not the same as the nucleus cuneatus, which is pretty obvious because the lateral cuneate nucleus is lateral. We'll talk about the internal arcuate fibers, Haju. Very good question. The lateral cuneate nucleus is responsible for conscious proprioception, and it's a little bit lateral to the nucleus cuneatus, right? So if we see it here, the unmarked ones would be right up here, the lateral cuneate nucleus area. This would be another nucleus cuneatus, and this is lateral to it. That's how you identify that. So if you see this and you say lateral cuneate nucleus, well, that's just kind of silly because that's not lateral, right? You're looking for something really lateral if you're talking about the lateral cuneate nucleus. And then Haji had a great question. What about the arcuate fibers? What are they? Okay, I'm going to go ahead and tell you. They are the crossing over of the dorsal columns. So how does that work? Dorsal columns come up the back. Okay, let's say we're talking about the cuneate pathway, the fasciculus cuneatus, comes up here, pops over to the nucleus cuneatus, and then the nucleus cuneatus sends its neurons to cross over, right? So the arcuate fibers, the internal arcuate fibers, are the crossing over of the dorsal column pathway. It's synapsed, and now we're talking about another order of neuron here, okay? And it comes over and it crosses. So the information that's synapsed here is going to ascend on the other side over here. And we're going to do some exercises with that. So don't worry if that doesn't make sense right this second. It should by the end of this lecture. Lesson, rather. Hate to call them lectures. Okay, so that's the crossing of the dorsal columns. Here's a key point. The arcuate fibers cross over and become the medial lemniscus. They do not ascend with the medial lemniscus. They become it. So they move across, and once they start going up, we're talking about the medial lemniscus. Yes. Yes. Absolutely they are. Absolutely they are. Okay? So these are the axons. We go from primary, right, so it comes in, it's all, dorsal root ganglion, and it comes up. And now we get the second order, which is going to take us to the thalamus. It'll synapse again in the thalamus, which we'll talk about later, and that would be the third order neurons. God have mercy. All right. Please stay. All right. Please. Good. All right. Great questions. The first order, second order, third order thing is going to make a lot more sense when you talk about the thalamus, because then you're going to have the whole picture. As a matter of fact, I can briefly pull up the whole picture just so that you can see it. Dorsal column system. Okay, right here. Okay. So as you can see, you have the first order neurons coming in from the touch, from proprioceptors in the arms, in the legs. They come up, and it's all first order until we get to the caudal medulla. So you guys tell me, let's see if we're tracking. What are these two nuclei right here? I'm not asking you which one is which, but what are these two nuclei in the caudal medulla? You tell me that. Let's see who's really on top of their game right now. Let's see. Very good, Haju. These are the nucleus gracilis and the nucleus cuneatus. So exactly as Gina said, these are the axons, the medial lemniscus, the arcuate fibers. These are the axons of the secondary neurons. Here's primary. They come up, they synapse. Okay, now they're secondary. They come all the way up in the medial lemniscus to the thalamus, right? The medial lemniscus to the thalamus. They synapse again, and lo and behold, we have the final third order neurons that go into the somatosensory cortex. Very good. Okay, and hopefully that makes sense to everyone. Okay, and let's go back to this and make sure I don't zoom in on my head again, because that would be stupid. And I did it again. Great. All right. Good. So we've got the internal arcuate fibers. So here's a question for you. Take the knowledge that we just gathered and use it to answer this question, which might be an exam question. I don't know. But if you know it, it really indicates that you know what's going on right now. Good. So you have plenty of time before the written exam, Haju, so I would advise you to take a bit of time and study that on your own outside of class. I really want to focus on the practicum and how to navigate the brainstem today. We're focusing on navigating the brainstem, so a little bit more anatomy, a little bit less function. But you definitely want to know that difference, and it's as simple as looking up the definition of each, the function of each in the slides and in the book. That is exactly correct. Nishi, Nandita, Sheena, Joanne, Amon, you're correct. Good. Why is that? Because before we spoke about the pyramidal decussation, we did not see internal arcuate fibers, so the strength system was crossing over below, inferior to the decussation of the dorsal column pathways, which is the internal arcuate fibers. Okay? Which means the crossing over of the dorsal column pathways is superior to the strength pathways to the pyramidal system. So if you got that right, Excellent, excellent job. I really think you're getting at the meat of what we're trying to learn here. Nice job. So let's have a question here. If we have damage at this level, and I'm not talking about dorsal columns or pyramidal, I'm talking about we take a magic wand and we lesion all of this and all of this and all of this and all of this, okay? Just in this area, somewhere in this area. Hopefully I'm making sense. What type of symptoms are we going to get? And I'll do a better job explaining it than I did asking the questions, I should hope. But let's see if anyone gets it. Okay, so what's going on here is that strength is crossing over. The dorsal columns are crossing over. They have not crossed over yet. So what do we see? Yes, bilateral symptoms. Good. Okay, so if we lesion here, we haven't crossed over yet. We're going to damage everything as from this side as it crosses over here, everything from this side as it crosses over here. We get bilateral symptoms right here. Okay? Excellent. Good. It is bilateral symptoms. So here's another question. And if you're getting this, then you're probably quite okay on the ipsilateral, contralateral, bilateral. If we damage above this level now, so here everything's crossing over. If we're above this, okay, above the decussation of the pyramids, above the decussation of the dorsal columns, and we lesion, what type of symptoms do we expect? Okay, so I'm saying above where everything crossed over, before everything's decussation, at the top, we lesion above this, what type of symptoms? Yes. Yes, it is contralateral. So if we damage above the decussation, contralateral symptoms. If we damage below the decussation, ipsilateral symptoms. If we lesion at the decussation, we get bilateral symptoms. Okay, yeah, I asked the question with a very poor phrasing, and I apologize for that. But what I'm trying to sort of have you visualize is, let's see if I can do it with this. Okay. Okay, so if we have two pathways, if my body is down here, my body is these fingers, right? Okay, down here. And we lesion up here, then the lesion is going to be contralateral to the damage. So if I lesion the blue up here, I get damage down here on the opposite side. If I lesion the green up here, damage down here on the opposite side. If I lesion on the bottom, I get damage on the same side, right? That makes sense. But if I lesion right in the middle, then I damage this as it's crossing, I damage this as it's crossing, and I get bilateral symptoms. Bilateral symptoms. All right? So hopefully you can use this to visualize. Maybe it's very, very small. Well, that was stupid. Okay. Well, that's fine. If it doesn't make sense, please ask questions in the chat. I did try to do this at the beginning of class on Thursday, so hopefully you guys saw that. All right. Moving on. So here, we're still in the medulla. Where are we here? Okay. So while I answer Nishi's question, I want you guys to answer the question. Are we in the medulla or have we crossed over to the pons? And give me a justification for your answer. Why are we and where are we? Yes, Nishi. Yes, Nishi. Because if they are crossing over, then and you lesion them as they cross over, then yes, you will get bilateral symptoms. Of course, the anatomy gets a little bit more precise than that. Aha! Good. So this is still the medulla. Very tricky question. Great job for those of you who picked it up. And if you didn't, that is okay. All right, it is okay if you didn't quite pick this up because it looks kind of Ponzi, but there's something missing. Look at these things. Look at the level. Look at the answer to the question right here. This big outpouching is the pons. We're still below it. This is not the pons. The thing that gave it away, is that we do not have transverse pontine fibers. No transverse pontine fibers, no pons at all. Okay? This is the medulla. This is the medulla. So, looks like pons, almost, but we're not there yet. And here is the giveaway. Okay? Here's what gives it away. This image right here. We see the olives. They're these serpiginous shapes down at the bottom, the inferior olives. We still see the spinal nucleus of 5, but we're getting skinny. We're moving out of it, right? And remember, this is a medullary structure, not a pontine structure. We see the spinothalamic tract. It's moved a little bit, right? A little bit. Right above the olive, so you might want to note that, because we want to know where that is at all times. And this thing, right in the middle, labeled with an M. What is this extremely useful godsend of a structure? What is this? All right, you guys tell me. Here at the junction of the medulla and the pons. What are we looking at here? Medial longitudinal fasciculus. Nice job, you guys. MLF, top notch. Good job. It's right in the middle, and it sort of helps you to orient yourself. Okay. The other thing we notice, which would help us identify this ain't pons, is that we have the medial lemniscus right dead in the middle. If we were in the pons, it wouldn't be in the middle, and you'll see that because the transverse pontine fibers are going to slap that thing out of the way. It's going to move up, okay? So all of these hints tell us this ain't pons country just yet, okay? We're not there yet. We're getting there, but we're not there. Nice job, nice job. I'm glad we cleared that up, okay? So we find the medial lemniscus. It hasn't been pushed up yet. We must be below the pons. We must be. It hasn't been pushed up yet. And we have the MLF right in the middle. And again, we're asking ourselves, why are we in the medulla? No transverse fibers. Now here's a good question for you. ICP, inferior C peduncle. Please tell me what peduncle this is, which inferior peduncle this is, and why. Okay? As Dr. Miller would say, your grandma would get this right. This is a very common sense question. What peduncle is this, and why must it be that way? It must be cerebellar. Nice job, Joanne. Nice job, Biggie. Good job. Right? Because we're not anywhere near the cortex. The cortex is all the way up here. We can't even see it. It's above these colliculi here, right? And we're all the way down here. But we know that this flat surface is here as a result of us having cut off the cerebellum. Okay? So what we might be getting into at this level is the inferior cerebellar peduncle. All right? Good job. Okay? Key structure at this level is the olive. Okay? If you miss the olive on the exam, you should be ashamed of yourself. It's huge, and it cannot be described, it cannot be confused with any other structure except one, but after tonight, you'll know how to tell those two structures apart. So when you see this thing, this is the olive, and we'll get into that a little bit more in a second. All right. So now, what section of the brainstem are we in, and how do we know for sure where we are? Put it in the chat. What section is this, And how do we know exactly where we are? Let's hear it. Let's hear it. Ugh, I hate to have such poor posture looking down at this second screen. That's right. Exactly. Exactly. We're at the lower ponds. We're just getting into the ponds. Just getting into the ponds. And we know this is ponds because these are the transverse pontine fibers. Let's say we don't remember what these things are. We don't know what this is. Look at the medial meniscus. It ain't that medial anymore. It's been pushed up. It's been pushed up by the transverse pontine fibers. That tells us that we are in the ponds. Here's another key thing about this level. What is this thing at the top? Is this an olive? It looks like an olive, but you guys tell me, is it or is it something else? And if it's something else, hazard a guess. What is it? Why can't it be the olive? Let's hear what you guys think in the chat. All of these ideas. Resolve this enigma for me. What am I looking at? Good. Good. Michaela, Haju, nice job. This cannot be the olive. And the reason why is because the olive is ventral, near the pyramidal system. It's ventral. This is not ventral. This is all the way in the back. This is dorsal. So what must we be looking at? Well, there's only one other thing that looks like, that has that serpiginous shape that we're going to talk about. That is the deep cerebellar nuclei. Okay? So here's what you should think to yourself. If I see transverse fibers and I see a serpiginous shape, I'm thinking deep cerebellar. If I see that shape and I don't see transverse fibers, it's the olive. If I see it on the ventral face, it's the olive. If I see it on the dorsal face, it's the deep cerebellar nuclei. Okay? Sorry if I said fibers, right? So hopefully that clears things up a little bit. And then here's another thing. MCP. Okay? We know that the M is medial. It's always medial or middle. We know the P is peduncle. Is this cerebral or is it cerebellar? And why? Okay? Give you a hint. We just saw the ICP. So what must this be? ICP, MCP. What is the MCP? Let's hear it. Cerebellar still. Good job. And if you look at the image, it gives it away. We're down here at the cerebellum. We're not at the top near the cerebrum. And if you look back, we just saw the ICP. And look at the image, because the gross anatomy really helps here. It's all narrow down here. There's not much going on. And then we get this big bulk of stuff surrounding. So here's the ICP. Then we wrap something around the ICP. So we have moved up to this level. And so now we get into the middle cerebellar peduncle. Okay, this is the middle cerebellar peduncle. I say a lot of stuff, Ijoma. You're going to have to specify. I don't know if I clarified it. If not, let me know exactly what you want me to clear up, and I will clear it up. Okay. And then on the other hand, we see right here an SCP forming. We have inferior, middle. This must be the superior cerebellar peduncle. Because remember, the midbrain is right before the cerebrum. We're still in the pons. We see the pontine fibers. If we see a peduncle, it must be cerebellar. Don't mess that up on the practicum. That is an easy point to get because of these magical fibers here that just give you answers to test questions. Okay. And Najoma, if you still have a question, let me know. We'll move on to compensate for a stream delay. Okay. So, again, we rehash. What's on the top left? Can't be an olive. We're in the pons, therefore we're looking at the deep cerebellar nuclei. How else can we tell them apart from the olive? You guys should know. Olives are ventral. These are dorsal. Okay? that should be enough to get you to these structures, and hopefully most of this now makes sense to you. Now, there's some things I didn't mention. Well, we didn't mention them that much in class, so don't worry about them too much. We did mention the pontine nuclei, which are these over here. They're kind of unique, but if you know where everything else is, and it's all multiple choice, it should be pretty easy to answer a question that asks you what the pontine nuclei are. And yes, Gianna. We're going to talk about the cerebellum. The cerebellum and its communication with the brainstem are detailed, and I don't want to oversimplify it right now at risk of making mistakes, so leave it alone. Your exam is going to be over the brainstem, so let's stay focused on that for just this minute. Okay. You can see them on both sides. They're just not labeled on both sides. This... okay, I see what you mean. Good question. I don't know the answer to it. Obviously, this is one section, this one set of slides that I'm teaching from. I would advise you to Google a couple other ones, and you'll probably see them, unless there's some unique anatomical feature I'm not aware of right now. But the answer right now is I don't know. Okay, but it's a good question. If you want to stay a few minutes after, I'll be more than happy to look that up, and we can discuss it. Okay. Good. So now, here's a new section. Oh, good. Yeah, there you go. So that's exactly the right thing to do. Not every image looks the same. It depends on the angle. It depends on whatever else. So yeah, you did the right thing. You looked up another image and you found that they're visible on both sides, which is exactly what we'd expect, because pretty much everything in the cortex is symmetrical. Nice job. Good job. Good independent research there. All right. So we see from this we're at the top of the pons, and I'm not going to beat this to death because you should already be really on top of it. This is the pons because it looks like an alien head as a result of the transverse pontine fibers, which are everywhere. They are everywhere. They're all over here. And at this point, all of the pontine fibers have manifested themselves, right? So the medial lemniscus has been shoved up as far as it's going to go. So it's gone from being a medial lemniscus over here to still being called the medial lemniscus, but now it's out and on the sides. Okay? So it's on the sides over here. M. M is the medial longitudinal fasciculus. It's still in the middle. Lo and behold, we know where the middle is because we know where that thing is. We have the superior cerebellar peduncle. Why not the inferior or the middle? Because we're at the top of the pons. The cerebellum was right here. We went from inferior to middle. Now we're at the top. Okay? So a lot of intuitive stuff. There is not way too much on this section. So if you know the pontine nuclei are somewhere in this mess of fibers, and you can identify these key elements, you're good. Okay. And one thing you want to be aware of is at this point, one thing that'll tell you you're at the top of the pons is that the spinothalamic tract and the medial lemniscus have finally come together. It looks like one long structure, but the vertical segment that we're seeing on the dorsal side is the spinothalamic tract, and this is the medial lemniscus pathway. So they've come together, and they make that very characteristic shape, and you can use that for points on the practicum. All right. So we've already identified what the peduncle is. We're still in the pons. Can't be cerebral. Yes, you do, Ashlyn. We all do. Okay, so this must be the superior cerebellar. And we spoke about this. Now here's a mnemonic for you. SUV, spinothalamic, is up and vertical. Okay, so the spinothalamic is up from the medial lemniscus in this image. It's up here. The spinothalamic is up and vertical. It's the vertical one. Medial lemniscus is the horizontal one. So you might get a practicum question, unlabeled, right? What is this? And you should know, based on where you are, based on that mnemonic, that if you're here, this must not be the spinal thalamic tract. All it can be is a medial lemniscus. And if it asks you what this is, SUV. Okay? If you want to memorize that, you'll have access to this later. Don't worry. All right? So here's a question for you. Let's have it in the chat. What is this? What is this that the arrow is stuck into right now? Let's see what you guys think. Okay. Any ideas? Nice. Good. So you see that really characteristic boomerang shape. You know the top is the spinothalamic tract. The horizontal segment is the medial lemniscus. Nice job. This thing with an M. Oh my gosh, it's still in the middle. How easy can we make this practicum? It's still in the middle. This is the medial longitudinal fasciculus, MLF. Any question that's asking you about something in here, best bet, it's the MLF because it's always there. All right? How do we know what part of the brainstem we're in? So you guys tell me, what part of the brainstem are we in and why? You can answer this as, what part of the brainstem are we not in and why? Hope maybe that'll make more sense. Have a go. Yes, it is the midbrain. Good, the midbrain, even better. Good, it's the midbrain. Tell me why. Mickey Mouse is a good idea. Or if you're auditioning for your neurosurgical residency and you want to impress everyone, it's because the transverse fibers are gone. You know exactly why this shape results. It's because we no longer have the transverse fibers. We have destroyed my computer. That's fine. Right, great. So we have lost the transverse fibers. So we are no longer in the pons. That's correct. We are in the, oh my goodness. We are in the midbrain, okay? And that results in this characteristic Mickey Mouse type shape that we spoke about on Thursday. Good job, okay? And we are in the midbrain. And you can see from the gross anatomy, it's very obvious where the medulla ends and the pons starts. And when you see this bulge go away, you're not in the pons anymore. We're in the midbrain. So if we were looking on the practicum, and I have seen this before, you see a practicum question where you see the gross anatomy and ask you, what are these things? That's one question. So answer that. Then you can ask it a different way. Same image, you can ask a different question. What are these two things? What are these two things? So what are the two on the bottom? What are the two on the top? And what section of the brain is indicated here? You guys tell me. Answer all or any of those questions that come into your mind. And just in case you get gross anatomy on the practicum, which you probably will. What are we seeing? What are we seeing in the gross anatomy up there? The laser was flitting around, hopefully. Let's see. Good. Corpus quadrigemina. The two on the top, superior colliculi. The two on the bottom, inferior colliculi. Good job, Anima. Good job, Gina. Everyone else, stop getting quiet. Say it out loud. It'll help. It will help. Okay? Good. And then this is about you, not me. Oh my God. All right. Everything that can go wrong will go wrong. Wonderful. Okay. So we know, hopefully, that this area around the aqueduct is the periaqueductal gray. That's a very easy one to get right on the practicum because where it is in the name. It's periaqueductal. It's right around the aqueduct. And now we have this thing labeled IC. We've already spoken about it. Can you guys tell me from this section what is the IC? And yes, Ashlyn, you're exactly correct. SC is vision, and IC is hearing. And how can you remember that? You just think, if you take your hands like this from your eyes and go back, your ear, the holes of your ears, right, are below the level of your eyes. And the inferior colliculus, which deals with hearing, is below the superior colliculus, which deals with vision. Okay? So that's exactly correct. And good. Haju, Nandita, Joanne, and Michaela, you're all correct. This IC is the inferior colliculus. Real easy, because it looks the same on cross-section as it does on the back, right? It's just little circle-ish shape. Okay? So those are the key features here, right? We have well, we'll talk about this in a second. We have the ML, the spinal thalamic tract, the paraaqueductal gray, the inferior colliculus. What is this? What is this thing, this CP? Think about what level we're at and tell me what this CP must be. What is it? What is it? What is it? All right. It's not awkward if I'm staring down at this thing. Very good, Joanne. So you know that we're up next to the brain. P is usually peduncle. It's not cerebellar anymore. We're above the cerebellum. This is the cerebral peduncle. Good job. So if you see a peduncle in the midbrain, it must be, because we're above the cerebellum, it must be the cerebral peduncle, a cerebral peduncle. Okay? So we just spoke about that. It's too easy, too easy. We move further up. We see the cerebral peduncle. We still see it in the same area. Very easy structure to get right on the practicum. We still see the medial lemniscus. It's in the same place, right? And it gets a bit vertical, and we know that this is a spinothalamic tract. This segment is a spinothalamic tract. Paraaqueductal gray is still paraaqueductal. Lord be praised. It's a miracle, right? The name gives it away. What is SC? Who can tell me what the SC is? Very easy test question. Very important structure. We're going to talk about it later in this course. You're going to talk about it in integrative neuroscience if you haven't taken that yet. So what is SC? This holy grail of structures. It is a superior colliculus, and these are the superior colliculi involved in vision. Okay? So if we lesion here, we're going to have dysfunction of saccadic eye movements. Okay? Very, very good. I'll go ahead and ask. What is SN? What is the SN? Who knows? Who knows? Is it the serous nucleus? Yes, the substantia nigra. Very good. The substantia nigra. Good job. Nice. So this is a pretty easy section. Oh my God, we finished, right? We still have a bit more to talk about today, but that was the overview of the brainstem. If you followed all of that, then you're good. You will get all of the practicum questions right, pretty much, as long as you're calm, as long as you're thinking, as long as you're using landmarks to identify things that are a bit harder to see. You'll be just fine, okay? Not very difficult at all, okay? There's also the cranial nerve nuclei up here, but I will not talk about those right now in the interest of time. Okay? So what's this, and what's it do? I'm not going to talk about the IB right now, just because it's been over an hour, and there's some more high-yield topics I want to cover before we finish. But very easy. You just look it up in the slides, okay? Or we can talk about it afterwards if you like. Good. This thing, this godsend, is M. It's the MLF. It's this thing that was the same from all of those levels of the brainstem that helped us find our center, right? And what does it do? Its day job when it's not saving undergraduates on Neuroanatomy Practica It coordinates eye movement. Okay? Common mistake. People will think it does vision because they see eyes and they see MLF. These people did not come to class. Okay? Do not be that person. This is not vision. This is not hearing. This is coordination of eye movements. Okay? Very good job picking up on that. Now, if you're paying attention to the chat earlier today, you will know the answer to this. The PPRF gives the initial signal, but who does it give the signal to? Okay? Dr. Miller described this in the PowerPoint when he was lecturing. He said this guy was the boss. Which structure here is the boss? All right? Which one is it? Good. Joanne, nice. Michaela, Gianna, good. This is cranial nerve 6. So the signal goes to 6 first. And let's trace it. If you ever see something like this in any neuroscience class, trace the arrows and it'll tell you what happens. So the PPRF, the parapontine or the paramedian pontine reticular formation, gives a signal from this thing, right? Gives a signal to cranial nerve 6, which goes up to the its lateral rectus and pulls it. So in this case, if we stimulate the orange one, it means we're looking, and remember, from the patient's perspective, we're going to be looking to the left. This patient will look to the left. So it tells cranial nerve 3, hey, you need to look to the left. Okay? And so everything is pulled to the left and everyone looks left. Now, if instead the PPRF had activated this one, it would be look right, and it would activate 3, and it would look right, and there you go. That's all there is to it. Okay? That's what this image is showing you. We'll go into quite a bit more detail when we do vision later on, but not tonight and not for this set of exams, so don't worry about it too much. If you understand the basics we just spoke about, then you're good. Okay? This is Benedict Cumberbatch. All right, more questions. So, this right here, well, I've ruined that. This right here is a lesion. Okay? I was going to ask it as a question, but my trigger finger was too happy. If we lesion right here after this point, then we get left eye abduction. So this is the left eye. Signal goes there, still abducts, but because the signal doesn't move up to nerve 3, the right eye doesn't agree and it doesn't adduct, adduct, okay? Right eye fails to adduct. This is a typo. This should be adduct. Sorry about that. And so that was what may have been wrong with the patient we saw in class, the video we saw in class. We said that this is a substantia nigra. This is a substantia nigra. Okay? So I'll give that to you. You give me what it makes. I want to know what the substantia nigra makes. Good. Okay. Good. So we're mainly in agreement. This is a substantia nigra and it makes dopamine. Now remember from the images, and I'll show them to you in a moment, that the dopamine synthesis was up and in the front. This is the midbrain. Hopefully we can all identify it because of the cerebral peduncle, at least. This is the midbrain. We are in the anterior side of the midbrain because this colliculi, the superior colliculi here are on the dorsal side. And so you should remember that the ventral top part of the brainstem makes dopamine. And that's what we see here. So the answer is B. So what's in the green circle? Okay. So if you're not familiar with the acronyms, we have inferior cerebellar peduncle, or inferior, cerebellar peduncle, superior cerebellar peduncle, inferior olive, or periaqueductal gray? And you all got it right, knocked it out of the park. It's D. It's the periaqueductal gray. You can tell because it is peri the aqueduct. Okay? Easy one to get right. Don't get the periaqueductal gray wrong. It's around the aqueduct. The name gives it away. All right? So let's do this question. What are cells of the VTA? All right, you guys tell me. Let's see. Got a couple votes in. I want to hear more voices on this one. I'm not giving this question away. Very good. Very good. Is it very good? Well, the axons would not be the pars compacta, right? Because remember that the pars reticulata means things crossing over, making a net, fish net. What looks like a fish net in the nervous system, it isn't cell bodies, right? Cell bodies. It would be axons, right? So the axons must be B. So someone tell me in the chat, what about that question confused you? A lot of people got confused, so I want to definitely address that. Okay. Good. Right. Good. The pars compacta is the pink stuff. It's the pink stuff. Okay? And therefore, the other stuff, the axons, is reticulata. Okay? So this hopefully answers both questions. You know that if the axons are reticulata, cell bodies are pars compacta. Okay? Do you have any questions on that? Okay. No? Good. All right, good. And we do want to point out, so here's sort of the rule for you. If you forgot, which everyone did, we're all getting a bit dreary, even I am. But what we want to see is that the name ventral tegmental area, it's ventral. This is the tegmentum. This is the ventral tegmental area. All right? Good. Okay. We're almost home here. Stay with us. Stay with us. Where is norepinephrine made? Let's see if we can get this question. Good. The locus ceruleus. And the locus ceruleus is up here in this area. It's in the pons, right? We see the pons here. We see inferior olives here, which means we also have, well, we're talking about something a little bit different here. The locus coeruleus is going to be the area in the pons that would be around where the periaqueductal gray will form in the midbrain. Okay? And if we get a bit lower, we start talking about the reticular formation, which is also involved in this, but that's going to be down around the medulla. We see a little bit down here. Okay? But the main thing you want to take away for the test and for the practicum, norepinephrine, locus ceruleus, and this is the locus ceruleus right up here. Okay? Again, I'm nowhere near as effective a communicator as Dr. Miller, unfortunately, but hopefully that made sense. Hopefully that made sense. A couple more. So answer 1 and 2, or 1 and the other 1. Both of these questions, what are the answers? As we finish up our brief survey of the or the neurotransmitters. Good. So the top one is C. The raphe, I don't know how to say that. I've never looked it up. Nuclei. And it's nuclei, multiple nuclei. So the answer to the second question is D, right? And I did not include the image, but if you look in the PowerPoint, you'll see that these things are everywhere. They're all over the place, okay? These nuclei are dispersed throughout the brainstem. Nice job, okay? Finally, let's talk about what you need to do to kill it on the exam. The first step was show up to class and see the material. Now, it rained on Tuesday, and this is Texas, so no one did that. But that's okay. You at least came here, and you got to see the material here. Many of you came to class. So step one complete. What's step two? Engage with the material by answering questions. You have to take the information and transform it into some sort of application. You need to be able to apply what you've learned in class. That means do the practice questions in the book. Do the practice questions that my colleagues, the other TAs have written. Come here, engage in the questions I ask you, answer them in the chat. That is step two. And all of you, thank goodness, have done that here today. Congratulations. What is the final step? What do you need to do to really take this stuff to a level of mastery and ensure you're going to ace the test? The last thing you need to do is teach the material. Okay? Now, for me, that usually means getting some people together, finding a room, and teaching it. Learning it myself, studying it myself, and then teaching it to some of my classmates. For you, that might mean doing that. It might be explaining it to your husband or wife or brother or sister or mother or your cat, or, get a bunch of strawberries and make a mound out of them and explain it to the mound of strawberries. Whatever you need to do, it needs to come out of your mouth in your own words. And if you've done that, then you probably have the material as close to a level of mastery as you're going to get it. And you're done. Okay? Step 4 is going to be to stop worrying about it. Okay? You saw the material in class. You studied the material in the book. You engaged with it. You answered questions. You came and you were active in this review. Then you explained the material. You transformed it into an output. Now you're done. Don't be nervous. Don't freak out what's going to be on the exam. It's going to be so hard, because at that point you need to be confident that you already know it. You already know it. Confidence precedes competence. So feel confident and you will be competent on the exam, I promise. All right? And this brings us to the end of our lecture. Thank you all for coming. Hopefully that was beneficial. Because this is widely considered as one of the harder parts of the course, I'm going to go ahead and post this lecture for you. And then if there were any mistakes in it, hopefully your classmates will point it out. I appreciate you all coming. You're all doing a wonderful job. Really appreciate the consistency. So go get some rest. Do great on the exam. I'm going to stay here for another minute or two if there are any questions, and then I'll post this up. All right? So good job. Go home. Or stay home. Get off your computer. Or do something else. All right. Let's see if we have questions. Yes, Bray. That is step 5. That is step 5. 10 points to Gryffindor. Nice. Well done. Of course, of course, of course. Thank you for coming. Don't worry about it, Jenna. Don't worry about it. We're talking about cerebellar peduncles. We're going to talk about those peduncles when we talk about the cerebellum. They're not nuclei. They don't have a function in that way, but they're a region in which something happens, and that thing that happens will become clear when we talk about cerebellum. You have enough to think about for this exam, so I'm not going to go into it right now. And I would advise you not to go into it in the book either. Not now. All right, wait for cerebellum. But good question. Okay, just be able to identify them the way we did today. No problem, Bray. Thank you for coming. Thank you for coming. What further questions do we have? If any. All right. Anytime, Gina. Thank you for coming. Thank you for being consistent. I see you here every week. I really appreciate that. All right. See if we have a few more questions. Maybe, maybe not. All right. I'll end the stream here, and any further questions can go in the group me. Thanks for coming.